Very good morning to all of you, and good afternoon and good evening to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Josep Maria Ribera from Barcelona, Spain, and he's going to lecture us on acute lymphoblastic leukemia and update on the management. This webinar, as usual, is brought to you by Mumbai Hematology Group, supported by Pfizer, Unipath, Lucent Life Sciences, and Nirvin Life Sciences. And I thank Team Pfizer, Unipath, Lucien, and Nirvin, Mr. Yash, Mr. Kalpesh, and the Team Perfect Square, Executive Committee of Mumbai Hematology Group. Our chief guest for the day, Dr. Bhushan Asthana from Lucknow. Our guest speaker for the day, Dr. Joseph Maria Ribera from Barcelona, Spain. All our discussants who are themselves very eminent hematologists as well as hemato-oncologists. And you participants who are spending your Sunday morning, afternoon, or evening from whichever part of the world you're logged in. This webinar is very well managed by Perfect Square. Let me brief you about next weekend activities. Next Saturday, that is 8th of March 2025 from 7 p.m. Indian Standard Time and 8:30 a.m. Toronto time, we have Dr. Vikas Gupta from Toronto, Canada speaking to us on myelofibrosis, fine-tuning the treatment with ruxolitinib. Let me introduce our discussions for the day, and they're displayed here in the alphabetical order. To start with, we have Dr. Abha Dubey from Ahmedabad, Dr. Abhinash Patnaik from Ahmedabad, Dr. Aishwarya Raj from Ahmedabad, Dr. Akanksha Garg from Ahmedabad, Dr. Ankit Rayani from Ahmedabad, Dr. Asif Sheikh from Ahmedabad, Dr. Bharat J. Parikh from Ahmedabad, Dr. Bhavin Shah from Ahmedabad, Dr. Chirag Shah from Ahmedabad, Dr. Eva Bhagat from Ahmedabad, Dr. Himal Shah from Ahmedabad. Then we have Dr. Hormaz Diyar Soli Sadri from Navsari, Dr. Jyoti Sawani from Ahmedabad, Dr. Komil Kumar Patel from Ahmedabad, Dr. Kazumi Patel from Mehsana, Dr. Khushbu Jain from Aurangabad, Dr. Manoj Toshniwal from Aurangabad, Dr. Manthan Kathodia from Ahmedabad, Dr. Meenu Angi from Ahmedabad, Dr. Nakul Tikare from Delhi, Dr. Prabodha Kumar Das from Bhubaneswar, Dr. Priyadarshini Peram from Bhubaneswar, Dr. Priyanka Samal from Bhubaneswar, Dr. Rajan Yadav from Ahmedabad, Dr. Sachin Bansal from Bhopal, Dr. Sandeep Shah from Ahmedabad, Dr. Satyarupa Mahapatra from Bhubaneswar, Dr. Savinay Digia from Bhubaneswar, Dr. Shruti Toshniwal Mantri from Aurangabad, Dr. Shyam Agrawal from Bhopal, Dr. Saurav Kumar Mishra from Bhubaneswar, Dr. T. Ramadevi from Ahmedabad, Dr. Tushar Pandey from Bhubaneswar, Dr. Umang Patel from Ahmedabad, and Dr. Venkatesh Ekbote from Aurangabad. Now it's time to introduce our very special guest. As the chief guest for the day, we have with us Dr. Bhushan Asthana from Lucknow. Let me introduce Dr. Bhushan Asthana. He is Dr. Brigadier Dr. Bhushan Asthana, is MD, DNB, Path, DM Hematopath, Deputy Commandant and Senior Instructor, Officers Training College, Army Medical Corps Center and College, Lucknow, as well as Consultant Hematopathologist at Command Hospital, Lucknow. He is a graduate and postgraduate in MD Pathology from AFMC Pune and was awarded the Pune University Gold Medal for MD Pathology in the year 1998. He then underwent 6 months training in oncopathology at Tata Memorial Hospital, Mumbai in the year 2000. Subsequently, he completed his DM in hematopathology from AIIMS, New Delhi in the year 2009. He has served as a hematologist and consultant at different service hospitals during his 25 years service in armed forces as a specialist across several postings. He has been a postgraduate teacher at Command Hospital, Lucknow, Command Hospital, Pune, and RNR Army Hospital, New Delhi. Besides hematology, he has been actively engaged with the practice of transfusion medicine and a postgraduate teacher in his subject. He commanded the prestigious Armed Force Transfusion Center, Delhi, at Delhi, Kent, an institute that pioneered the use of frozen RBCs for transfusion support in India. He was also the head Department of IHBT, that is Immunohematology and Blood Transfusion, at AFMC Pune for over 2 years. He had been actively involved in the ongoing at RNR Army Hospital, Delhi, and Command Hospital, Pune. He is a postgraduate examiner at AIIMS, New Delhi, MUHS Nashik, and KGMU Lucknow, as well as DNB Pathology Examiner. He is also a PDCC Hematopathology Examiner at AIIMS Jodhpur and KGMU Lucknow. His areas of interest are coagulation and immunohematology,
Hematology.
a part of
A
coagulation
part of
workshops at AIMS, New Delhi, and SGPGI, Lucknow. He has conducted quiz in hematology for postgraduate students, including the zonal level PG quiz at Hematocon. He has authored and co-authored nearly 25 publications in national and international journals, as well as chapters in books and contributions in hematology quiz books. Presently, he is posted at an administrative appointment as Deputy Commandant at Officers Training College at Army Medical Corps Center and College, Lucknow. It's my privilege to invite Brigadier Dr. Bhushan Asthana to inaugurate our webinar and give some words of wisdom. Over to you, Professor Dr. Asthana.
Thank you so much, Dr. Amit Khurana, for that generous introduction. I am truly humbled by your words, and at the outset, I must thank the Mumbai Hematology Group for giving me this honor and privilege to be the chief guest today for this webinar. And like everyone else, I'm also joined by my colleague, Dr. Joseph Maria, who will be talking to us on ALL. Hematology, as I have seen, I think I owe it to Dr. MB Agarwal because as a young postgraduate, I remember when I was posted in Goa, I happened to attend one lecture of his, which was on life without platelets, and that is what set the ball rolling. And thereafter, I was so fascinated by the subject that I went on to pursue my DM in hematopathology from the prestigious AIMS New Delhi. And as we see the way hematology has evolved over years, it's actually at an electrifying speed. And the beauty of this subject is this is one place where we get to grow and learn along with the clinicians, and the association with the clinicians and the patient starts off right from the time of the diagnosis, continues throughout the management of the patient, as well as carries on when the patients are on follow-up. So at no stage do we let go of the patient by just giving a diagnosis and then forgetting about it. So this is what makes the subject fascinating, and the way it is growing, the newer classifications that have come in, the shift from the morphological definition of tumors to a more prognostication based classifications, which are much more meaningful in clinical relevance, have all led to a paradigm shift in our learning. And whether it is the advent of immunotherapy and the targeted therapy on the clinical side, or high precision, accurate diagnostic techniques like digital droplet PCR or NGS, which are giving us so much of information, or the use of digital pathology to reach out to each other and consult, it is getting better and more interesting with every passing day. And not to forget these excellent webinars, which is an initiative of MHG, which enhances our learning at a very frequent pace. So with this, I would like to thank MHG again, and just a word that hematology can be a very small beginning at any place it can be practiced in whatever measure it is available, and we need to grow from there. If you're lucky to be at a hematology center, that's perfect. But even from a smaller place, we can have a small beginning. And that's how I have learned from my initial postings in very small hospitals till I reach our bigger tertiary care centers. So this is what I have to say. And this is a subject I think which is very close to each and everybody's heart. And thank you for giving me this opportunity. And over to Dr. Kirana again.
Thank you, Dr. Asthana, for your wonderful words and kind words. I think your message is very clear. Whatever the center you are, at a small center or big center, I think hematologies are required at every center. And you will do best in your career from whatever center you start with. And that's the message to all our budding hematologists. Thank you for being and accepting our as a chief guest for the day. Thanks a lot. Let me share the screen again. So now it's time to introduce our guest speaker for the day. We have no other than Dr. Joseph Maria Ribera from Barcelona, Spain. We have heard sir many times, and he's our teacher now in acute lymphoblastic leukemia. Whatever updates we are learning from him in ALL is all hats off to Dr. Ribera. So Dr. Ribera, Joseph Maria Ribera, is professor and head clinical hematology department, ICO, Hospital Germans, Trias I Pujol, Joseph Carreras Research Institute, Universitat Autónoma de Barcelona, Badalona, Barcelona, Spain. He's a director of the stem cell transplantation unit at the Hospital Universitari Germans Trias I Pujol and head of the clinical hematology department for the Catalan Institute of Oncology, also at HUGTP. He joined the Joseph Carreras Institute at its creation and participated in the process of creation of the Acute Lymphoblastic Leukemia Research Group. He is professor of medicine at the Autonomous University of Barcelona. He teaches postgraduate courses at UAB, University of Barcelona, the Universidad Internacional Menéndez y Pelayo, and the Escuela Nacional de Sanidad, as well as carrying out other varied teaching duties. His work and publications have made him well known internationally, and is a member of the steering committee for acute lymphoblastic leukemia of the European Leukemia Net and the European Working Group for adult acute lymphoblastic leukemia. His research focuses on the study of new treatment approaches and prognosticate factors in adult ALL, and he collaborates closely with the lymphoma research group in the study of therapy and prognosis in HIV-related lymphomas. He has authored as well as co-authored more than 500 published clinical papers and 100 book chapters on hematology, oncology, and internal medicine. Today, he's again with us and is going to lecture us on acute lymphoblastic leukemia and update on management. Well, thank you so much. Over to you, Professor.
Okay, thank you, and good afternoon. And so, thank you for your words, and I'll share my presentation. Can you see it?
Not yet, sir. No, yes.
Okay.
Yes. Yes.
Okay, so my talk for today is to have and to update the treatment of newly diagnosed adult acute lymphoblastic leukemia. So the first thing that we have to take into account is that the diagnosis of ALL is increasingly complicated now because we have many techniques that allow us to define new genetic subgroups. All of them have a small frequency and different prognosis. This complicates very much now the how to standardize the treatment of acute lymphoblastic leukemia. So, for example, for B-cell precursor ALL, new genetic subgroups such as DAX4, NUTM1, ZNF rearrangements, PAX5P, ATR, have been defined. All of them are associated with good prognosis, but have a very, very low frequency. And for example, for groups with poor prognosis, a part of the classical, there are other genetic subgroups associated clearly with poor prognosis, and there are many associated with an intermediate prognosis. So it makes the diagnosis complicated apparatus, and this has either in children or in adults, it has clear prognostic significance. For example, in adults, the DAX4, the PAX5P, ATR are really associated with good prognosis. And for example, PAX5 alt or other are associated with a poor prognosis. And the same occurs in children. So this is the spectrum for B-cell precursor ALL. We have analyzed it now in our current trial in Spain, and we have replicated this. For example, those patients with PAX5P, ATR, or CNF 38-4R are associated with excellent prognosis and virtually no relapses. And on the contrary, those with KM2 rearrangement or low hypodiploid are associated with poor prognosis or even PH-like. So, and this is closely correlated with the probability of relapse. So this is the panorama for B-cell precursor ALL. But now TALL is also complicated, and in a very nice paper from the St. Jude Hospital, they have defined it in a more than 1,000 children with TALL, at least 15 subtypes of TALL, all of them or many of them with very low frequency and associated to clearly different prognosis. So really the diagnosis is complicated. And now even in TALL, that is complicated because the very early precursors, ETP-ALL, so it's like a hybrid myeloid lymphoid leukemia, are complicated this by another entity recently defined that is near ETP, another is ETP-like, and the remaining subtype. So really, we are facing in a complicated scenario for both BALL and TALL. But anyway, there have been clear improvements in the therapy of ALL, either for pH positive, pH negative, and even with a lesser degree in TALL. Well, let's see what we are doing for selection of ALL therapy. First of all, we define an ALL of B-cell precursor or TALL. And in B-cell precursor ALL, it's important to say if there is a mature BALL, a Burkitt-like ALL, so that has a specific therapy with rituximab, and other subtypes clearly with different therapies, the pH positive ALL and the remaining pH negative ALL. We have to make an effort to distinguish between pH-like ALL and the remaining subtypes. pH-like ALL encompasses 20% of ALL, B-cell precursor ALL, especially in adolescents and young adults. So, and for TALL, it's essential to distinguish the ETP-ALL, early T-cell precursor ALL, from the remaining subtypes. This is our schema for defining the possibilities of therapy. Why? Because we have some possibilities such as immunotherapy, or direct or targeted therapy that are especially used in several subtypes of ALL. So for pH positive ALL, it's very important now to distinguish two subtypes. One, a pure lymphoid, in which the leukemogenic event occurs in a precursor committed to the lymphoid development, and a CML-like ALL in which the leukemogenic event occurs in a more multipotent progenitor. Both subtypes, fortunately for us, up to now, have the same prognosis, but this has very challenges for MRD detection. For example, when we in the typical lymphoid pH positive ALL, there is a clear concordance between the BCR-Abelson and IGTCR for assessment of MRD. Whereas in multipotent or pH-like ALL or CML-like ALL, really the results could be discordant, being perhaps IGTCR the best tool, because identifies the pure leukemic population, whereas the assessment of the fusion gene detects as leukemic some progenitors that normal progenitors that carry the BCR-Abelson rearrangement. Well, fortunately, as told now, the CML-like and the typical ALL have the same outcome. This is important. And let's let's say, the panorama of how TKI are approved for clinical use in Ph positive ALL. They have changed clearly the treatment of Ph ALL. Imatinib was the first and is approved for diagnosis and for first and second line. Dasatinib is approved after resistance or intolerance to imatinib. Nilotinib and bosutinib they have not been approved for Ph positive ALL therapy, and ponatinib is approved worldwide in case of T315Y mutation in de novo or after dasatinib failure or in more than first line. And fortunately for US, they have approved also the ponatinib for newly diagnosed Ph positive ALL in any case. Well, the history of the treatment of Ph positive ALL has evolved from the first step that was incorporating imatinib to chemotherapy. Then dasatinib, nilotinib were incorporated and chemotherapy was de-intensified, and then ponatinib also has been combined with chemotherapy and with clear success. So really usually patients were submitted to allogeneic stem cell transplantation, especially when imatinib or dasatinib were used combined with chemotherapy. Another movement began with combining just TKI, imatinib, or dasatinib with prednisone, so really minimal therapy and with TKI, and has continued incorporating ponatinib with prednisone, and recently the combination of second or third generation TKI with blinatumomab. This is the history of the modern history of the treatment of ALL, and this has consequences, and this is the outcome over time in cases of MD Anderson, that they initially used imatinib combined with hypercibat, then dasatinib, then ponatinib, and finally ponatinib with blinatumomab, chemo-free, with outstanding results. And this improvement is really a big success in the therapy of this disease. When we combine TKI with intensive chemotherapy, the most outstanding effect was achieved with hypercibat ponatinib. In the last update of this study, that they had a probability of overall survival of 75% of the patients. Most of patients achieved a complete molecular response, and really this was associated with a good outcome. And the effect of transplantation, this is not a randomized study, transplantation was done by physician decisions, but really transplantation that did not improve the results of just combining hypercibat and ponatinib and giving ponatinib as maintenance also. In the Spanish trial, the PONALFIL, we combined the standard BFM therapy and ponatinib during induction and consolidation, and then proceed to allogeneic stem cell transplantation to all patients, and we only used maintenance with ponatinib in case of persistence or reappearance of MRD. Our results, the transplantation rate was very high. The transplantation toxicity was very, very low, and really 2/3 of the patients did not need any TKI as maintenance after transplantation. And this was associated with a very good overall survival and event-free survival. Well, now the tendency in clinical trials, it's important to set this, is use TKI with low intensity chemo or even without chemotherapy. The only phase 3 trial combining ponatinib versus imatinib in Ph positive ALL was published last year, and the main objective was to demonstrate the primary endpoint, the negativity of MRD at the end of induction, and this was achieved significantly in the ponatinib arm. Ponatinib was combined with attenuated chemotherapy and compared with the same attenuated chemotherapy with imatinib and a randomization 2-to-1. And this was associated to an improved progress-free survival for the ponatinib arm and a trend, but non-significant trend in event-free survival. This prompted to FDA, the US FDA, to approve ponatinib in first-line therapy for all patients with Ph-positive ALL. Okay, it was done 1 year ago in US. The next step was to combine, in this case, second generation TKI plus immunotherapy, and this was the trial by the Italian GMEMA group, and they also showed a very, very nice outcome with overall survival probability at 4 years of 80%, really very, very, very nice. And they demonstrated what was observed in previous studies, that the PH-like phenotype really was associated, the Icaros plus phenotype was associated with a poor outcome. So it's important, but this was also observed when ponatinib was combined with hypercibat. So it seems that within Ph-positive ALL, the Icaros plus signature is associated to poor prognosis, even in the immunotherapy and TKI era. So the next step was done by MD Anderson, combining ponatinib and blinatumomab in this scheme that there is an absolute lack of chemotherapy. Just the chemotherapy is used as a CNS prophylaxis and no more. And really, the updated follow-up of this study showed a very, very promising outcome. The event-free survival 77%, and really very, very, very nice. And only 2 patients were transplanted in CR1. So this study is really a chemo-free and transplant-free trial with outstanding results. The Italian group are randomly comparing the standard therapy, that is the imatinib, chemotherapy, and transplantation, with the ponatinib plus blinatumomab. This study the randomization is closed, but the results are not shown. And what was only shown at last ASH meeting was the outcome of the ponatinib blinatumomab arm, and really the very nice complete hematological response, very nice molecular response at the end of induction or after 2 cycles of blinatumomab, and this was higher, it was superior to the historical historical dasatinib blinatumomab trial, the DIALBA, 46 versus 29, 74 versus 60. Only the transplantation that was done in 40% of patients in the dasatinib blinatumomab trial was reduced to 12% in this ponatinib blinatumomab arm. And really, this was associated with an outstanding overall and disease-free survival. Well, really, the events were low and really very, very interesting. Well, when we compare the immunotherapy era, the dasatinib blina, there are two trials, one in older patients, but really that all of them showed a high rate of pH, of PCR MRD negativity, and a promising survival at all years, that at all age. So it's very, very important. And the transplantation has been reduced over time. And the relapses are very low. Half of them, almost half of them, were occurred in CNS, that prompted to the researchers to intensify the CNS prophylaxis in patients who did not receive systemic chemotherapy. And now, when this intensification of CNS prophylaxis, the CNS relapses reduce dramatically. Well, this is the case that this in this analysis at MD Anderson compared the 8 shots of intrathecal therapy versus 12 shots, and they showed clearly that with 12 shots of intrathecal therapy, the CNS relapses reduced to 0. So very, very important. Well, now it's time, as explained, to the randomized therapy. We are awaiting this trial, and I hope that we will have the results soon, comparing the ponablina versus the standard chemotherapy, and really could have light, and we expect that the ponablina will be clearly superior to the control arm. And if this is the case, really could be the standard of care of newly diagnosed patients of Ph positive ALL. So, what about transplantation? Transplantation was extensively used when we treated patients with imatinib or dasatinib and chemotherapy. But what has been observed in retrospective studies is that those patients who achieve the complete molecular response at 3 months from the diagnosis do not benefit for allogeneic stem cell transplantation. The overall survival is equivalent, although the relapse is inferior in transplanted patients, but this is counterbalanced by the increase of treatment-related mortality. So it seems that when a good molecular response is achieved by 3 months, really perhaps in these patients the probability or the need of transplantation could be reduced. But as commented before, the Icaros Plus signature is associated with poor outcome. This is in the ponatinib chemotherapy from MD Anderson, the dasatinib blinatumomab from the Italy. So really, this is especially poor prognosis groups, and perhaps these patients will still need allogeneic stem cell transplantation, even if they are in complete molecular response. The definitive value of transplantation could come from this study from France. Those patients received ponatinib, blinatumomab, and chemotherapy, a small amount of chemotherapy, and then they are randomized to allogeneic stem cell transplantation or chemotherapy, and in both cases preceded by blinatumomab, and in the chemotherapy arm there was a maintenance therapy with blinatumomab. This randomization between allogeneic or immuno chemotherapy could shed light in order of the need of allogeneic stem cell transplantation. In any case, another question is, should us continue with maintenance therapy after allogeneic stem cell transplantation? And the recommendations from transplant groups are that those patients who have undetectable MRD after transplantation we can use indistinctly the prophylactic or the preemptive strategy, especially the last one, especially if we are capable of making a strict monitoring of the MRD in these patients. Okay, so this is my view in how to treat PH like ALL. We have to use our frontline therapy, the frontline therapy that could be used for imatinib chemotherapy, dasatinib chemotherapy, or ponatinib chemotherapy, and then we have to analyze the MRD at 3 months. If the MRD is negative and the patients have not genetic risk, perhaps we can skip transplantation. But if these patients, despite being MRD negativity, those who have high genetic risk, they will receive allogeneic stem cell transplantation. For those patients who are MRD positive, we have the chance to change the TKI that we use at that diagnosis, incorporate immunotherapy, because this is in this case, blinatumomab, because this is approved for this situation. And then in those cases, perhaps we should continue with allogeneic stem cell transplantation. This is what we are doing in Spain in our clinical trial. We begin with imatinib and attenuated chemotherapy. Imatinib is the only TKI approved in Spain for first-line therapy, and those patients who achieve complete molecular response continue with this therapy. And if they are fit and they have no genetic risk, they continue with maintenance therapy. And if they have genetic risk, this means Icaros plus signature, they follow with allogeneic stem cell transplantation. If they have no complete molecular response under imatinib, we introduce ponatinib and we apply the same policy. Ponatinib and chemotherapy, and those fit patients without genetic risk continue with maintenance, and the fit patients with genetic risk, allogeneic stem cell transplantation. It's clear that for unfit patients, we can use imatinib or ponatinib with maintenance without transplantation. This is our trial. We are more than 100 patients included in this trial, and we will perform in 3 months the first analysis in this of the results of this trial. The history does not finishes here. The classical TKIs are competitive with the ATP binding site of the Abelson gene, but there are allosteric inhibitors so that they do not compete with the binding site, that just to modify the configuration of the spatial configuration of the Abelson gene, and there are two of these allosteric inhibitors. One is olverembatinib. It has been developed in China, and really it makes a change in the spatial configuration of the ATP binding site, and this promotes their activity. And another is asciminib that acts outside this kinase domain pocket, and they use another pocket that is the myristoyl. So these these two TKIs are actively investigated. For example, in a very recently published phase 1 study, asciminib was combined with dasatinib and prednisone in newly diagnosed patients, and really they demonstrated a good hematologic and cytogenetic response, and a good MRD 3 and 4 MRD negativity. This MRD 3 and 4 improved over time, and really this and the toxic cost was very low, and really this is a promising combination for treatment in of newly diagnosed ALL. This trial now has been amended by the addition of blinatumomab, and now this trial combines asciminib, dasatinib, and blinatumomab, and we can expect the results in perhaps in 1 year. The other inhibitor is olverembatinib. There are several trials, all of them developed in China, in newly diagnosed Ph-positive ALL, either combined with attenuated chemotherapy, or combined even with venetoclax and attenuated chemotherapy, either combined with blinatumomab. This combination is with very nice results. So and really there are also promising results that make this drug with a promising future in the therapy of Ph-positive ALL. Olverembatinib is active in patients with T315Y mutation, as occurs with ponatinib. So really a new promising drug. What occurs with in B-cell precursor Ph-negative ALL? Improvements have also occurred over time, especially in young patients, less in elderly patients, but there are also some interesting results. Let's see. There are, for example, several studies, classical studies with chemotherapy and risk-oriented allogeneic stem cell transplantation. For example, the Spanish trial showed a good complete response and promising overall and event-free survival, but this is the top. We have reached the top combining chemotherapy and allogeneic stem cell transplantation. We need more than this. We can cure perhaps 50% of patients, but we cannot overpass this top. No? And really, there are important questions that are emerging. So most trials are MRD guided, but perhaps is not the only tool. Perhaps we can look for other complementary tools of MRD for response. And especially the most important thing is not achieving MRD negativity, but achieving a deep MRD negativity. This is the goal, no? And this has been associated with improvement in the survival. We have to better define the role of allogeneic stem cell transplantation in CR1. We have not forget the white blood cell count. White blood cell count is in B-cell precursor ALL is still a poor prognostic factor, and we have to not forget to give an adequate CNS prophylaxis, and really. And we now we will incorporate in the near future. In fact, we are now incorporating immunotherapy in first line, and perhaps this can change the role of MRD and the role of other important prognostic factors. Well, for example, this is a study, a very interesting study presented at last ASH, randomly compared the transplant or maintenance chemotherapy in adult patients with high-risk Ph-negative ALL with MRD negativity, and the results were really not different in transplantation versus chemotherapy, although the patients with TALL fare better with chemotherapy, significantly better than transplantation, and there was a trend for the opposite side for B-cell precursor ALL in whom transplantation could be better than chemotherapy, although not statistically significant. But this shares the light that perhaps transplantation is not the solution with the patients achieve an early MRD negativity despite having high risk features and Ph negative ALL, of course. So what is more important is to achieve deep early MRD negativity for B-cell precursor ALL, because this is associated with very, very nice outcome, and compared with not achieving this, if we can not achieve the deep MRD negativity, perhaps these patients who should be transplanted, because if not, they relapse. It has been demonstrated in a study from MD Anderson using the clonoSEQ MRD, the next generation MRD tool with a sensitivity of 1 to 10 to minus 6. Okay, so we in Spain, we are now analyzing we are not we are convinced that MRD is not the only tool for selecting the treatment of the patients, and we consider it also the genetic risk at baseline. And in our study, we combined the MRD criteria with the genetic criteria to allocate or not to patients to allogeneic stem transplantation. And we presented the results at last ASH in our study, following this allocation, 40% of patients were received consolidation and maintenance, and 61% of patients were submitted to allogeneic stem cell transplantation. And what we showed that there was a subgroup of patients who achieved a complete response. Of course, there are MRD negative at the level of 1 to 10 to minus 4, and have a standard risk genetics that show at a 90% of survival. So this is important. And when we use only MRD negativity, but the patients had high genetic risk, this is the yellow curve, the outcome of these patients was poor. So this is this suggests that we have to combine MRD and genetic assessment in order to better define, better select the patients who will submit to allogeneic stem cell transplantation. Okay, so really, another important issue is how to prevent the CNS relapse, and very nice study conducted in France, and comparing the results of a protocol that included cranial irradiation with a contemporary protocol that did not include cranial irradiation. They showed that omitting cranial irradiation in this study was associated with the increased CNS relapse. This moved to the French group to reintroduce the prophylactic cranial irradiation. This is only one group. Most groups still not use cranial irradiation, but in the experience of the French group, it seems that cranial irradiation diminishes the probability of CNS relapse. Now we are in the era of immunotherapy, it's clear. The first immunotherapy approved was blinatumomab. Next, inotuzumab was approved, and the last immunotherapies approved are CAR-T, Tisacel, Brexucel, and Obecel. Obecel in US only, and probably in the near months in Europe. But really, so we have monoclonal antibodies and CAR T cells as the new tools for the therapy of ALL. No? And really, blinatumomab is approved for relapsed and refractory in adults and children for MRD positive ALL, and now by FDA and also by EMA in Europe have been approved for use in first line in consolidation in Ph negative ALL. Inotuzumab is approved for relapsed refractory ALL in adults and by FDA in children also. And Tisa-cel, Axi-cel, and Obe-cel are approved for refractory in adults, refractory relapsed in adults, and children and AYA at different ages according to the construct. Really, this is the present. The future in blinatumomab is the development of subcutaneous blinatumomab. Inotuzumab is now investigated in first line in adults as has been done in blinatumomab. And really, the CAR-Ts are incorporated in clinical trials in CR1 for patients with very high risk ALL. These are ongoing clinical trials, and we will expect with increasing interest the results of these trials. Blinatumomab, when was added to the interfund chemotherapy for infants with KMT2A rearranged ALL, just adding one cycle of blinatumomab really was associated with a reduction of the cumulative incidence of relapse, improvement in DFS, improvement of overall survival compared with those patients treated exclusively with the same chemotherapy. So this is one clear example that introducing blinatumomab in this case in first line therapy early in the therapy in this study is associated with a significant improvement of the results. In the last touch meeting, and just published now in the New England Journal, also patients, children with a standard risk ALL, but with average of high risk features, were randomized to receive chemotherapy only or blinatumomab plus chemotherapy. And what was clear that the addition of blinatumomab in this subgroup of patients really was associated with a reduction of relapses and a significant improvement of disease-free survival. Another message for the early introduction of blinatumomab in newly diagnosed patients, in this case pediatric patients with B-cell precursor ALL. Now there is ongoing a very important study that I expect the results will be shown very soon in those patients with high risk, pediatric patients, high risk ALL. After induction and consolidation, they were randomized to receive blinatumomab or chemotherapy, and then continued the therapy. And the results of this randomization are expected with very interest. What we know from this trial is that the tolerability of the blinatumomab arm was better than the chemotherapy arm, but we do not have up to now results on efficacy. Well, what we know in adults, in older adults, is really some results of phase 2 trials that are introducing immunotherapy, either inotuzumab or blinatumomab, really, and with promising results. These are older and elderly patients, but the complete response exceed 90% that it has not previously seen, good quality MRD, and really promising overall survival. Short term, but really very, very nice. And some examples, for example, the German study incorporating blinatumomab in early consolidation, before consolidation, and alternated with consolidation blocks of chemotherapy, and they showed an increase of molecular response after the introduction of blinatumomab, and it was translated in a promising overall survival and event-free survival. They are older patients, so, and this curve could be perfectly seen in young adults. So these are good results in older adults, and when compared with the contemporary series of patients without not included in the trial, the results appear to be better. With inotuzumab, this is a very, very interesting study that the initial one also conducted in Germany, in which the induction was exclusively done with inotuzumab. Combined of rituximab, of course, if they were CD20 positive. Those patients received 3 cycles of induction, exclusively based on inotuzumab, the first at a standard dose, the others at attenuated dose. And what was important is that at the end of cycle 3, really all patients achieved complete response with inotuzumab as a single drug, and they have a good percentage of MRD negative, and this was translated in promising event-free survival and overall survival, acceptable relapse rate, and low rate of death in complete response. Is a very, very important study showing that immunotherapy, just immunotherapy, beginning with immunotherapy, in this case with inotuzumab, really could have a good clearance of the disease, and that allowing them to incorporate the standard therapy. In Europe, also, the EWAL group introduced inotuzumab combined with attenuated chemotherapy in the induction, and continued with the standard chemotherapy in consolidation and maintenance in a series of more than 100 patients. Really an important median overall survival of 55 years at 55% at 2 years, and really a very good MRD negativity achievement. Is another way that we can safely incorporate inotuzumab during induction in elderly patients with Ph negative ALL. The next step is, if inotuzumab works very well as single drug, why not to eliminate the chemotherapy and make a therapy that first ino, then blinatumomab, first ino in induction, then blina in consolidation, in order to avoid the toxic effect of chemotherapy. This phase 2 trial showed that really in a series, in a limited series of patients, achieved a good complete response, and promising 1 year event-free survival. Although when we see the overall survival, we see that a plateau has not achieved. But I think that at least this approach is very good for putting the patients in complete response, and perhaps then incorporating other elements of the therapy. Okay, so what occurs in young patients with Ph negative ALL? Again, we have several studies in which the complete response with combining combining chemotherapy and immunotherapy in front line, really they achieve a good morphologic response, very, very good MRD negative response, and promising overall survival. And several examples, for example, one from Italy, they incorporated blinatumomab during the consolidation, early and late. And what we demonstrated that with the first blina introduced during the consolidation, an increase in the MRD negativity to 70% before blina to 93% after blina. So, and this was associated with a promising outcome. What was important is that before blinatumomab, the MRD had a prognosis impact, and when was negativized after blinatumomab, the prognostic impact of the MRD disappeared. So it's a clear example that when we use effective therapies that clear MRD, the prognostic impact of MRD disappears. Another study, a very nice study, again from MD Anderson, they combined inotuzumab and blinatumomab, both drugs, in a series of patients, 75 patients, and they demonstrated and they showed first a really a very, very nice outcome. There are young adults, okay? Very nice results. But the best results were achieved when combining inotuzumab and blinatumomab, better than using blinatumomab only in the cohort 1. Cohort 1 only only blinatumomab, cohort 2 inotuzumab and blinatumomab. The combination improved the results. Well, we have only one phase 3 trial that demonstrates that the incorporation of blinatumomab during consolidation in MRD negative patients had superior results than the standard consolidation, chemotherapy-based consolidation. So these patients, this part is the most important of the trial. Those patients who were MRD negativity at the end of intensification were randomized to blina and chemo for consolidation versus only chemo. And really, those patients had an important advantage for overall survival in patients who received blinatumomab in consolidation combined with chemo versus those who achieved chemotherapy only. And this was clearly shown in almost all situations. And really, that what was important is that this special advantage was clearly seen in patients younger than 55 years. This was a very nice advantage. But when the age was over 55 years, the effect of blina in consolidation was very low, and in fact it was not statistically significant. Okay, so and what is important in a post-hoc analysis of this study is that that the effect of giving the 4 cycles of blinatumomab, this effectively occurred in half of the patients, and those patients who received the 4 cycles had better results than those patients who received less than 4 cycles, and was clearly significant in the outcome, and we receive only 1 to 2 cycles. This advantage was not statistically significant. So it's not important to program 4 cycles of blina in consolidation, but they have been effectively given. Okay. Okay, this prompted to FDA to an accelerated approval of blinatumomab in first-line therapy in consolidation, and this has been followed by approval in Europe 1 month ago. There are now clinical trials ongoing. This is the Golden Gate study that in patients older than 55 years, the experimental arm includes blinatumomab not only in consolidation, but also in induction. This study and is compared with the standard of care chemotherapy, and really the results of this study are expected, but this study is still ongoing. We do not have any results. What we do know is in a pilot study is that the experimental arm is feasible and it is not associated with important toxicity, but what we do know is the results of the randomized part of the study. Also for inotuzumab there are randomized studies. This is one study from the Alliance consortium from US, and really patients, adolescents and young adults patients after induction were randomized to receive 2 cycles of INO versus no INO, and then continued with consolidation and maintenance. This study was closed prematurely because it was the significant increase of infectious events in the INO arm, although there was some insights in that the incorporation of INO was more efficacy but reduced the progression. But at the end, the event-free survival and overall survival were equivalent before the discontinuation of this trial. This trial is amended, and the problem it was that the INO dose designed was perhaps higher, and now they are attenuating the dose of inotuzumab and will add blinatumomab in the consolidation or maintenance phase. Well, now not all is immunotherapy. A recent study recently published combined venetoclax with low intensity chemotherapy in achieving good results in de novo ALL, and were associated with promising overall survival. This combination is feasible, and why not will incorporate venetoclax in first-line therapy, but we have to demonstrate this in randomized studies that are planned now currently. Well, apart of chemotherapy and monoclonal antibodies, we have prospects of targeted therapy in Ph-negative ALL, and really, for example, for KMT2A rearranged, there is an activity, intense research activity with menin inhibitors. They have demonstrated 20% of complete response in relapsed and refractory patients with this rearrangement, and now there are studies incorporating these menin inhibitors in first line clinical trials, of course, and there are other possible targeted therapy for specific subgroups of ALL. Really, we are expecting to incorporate chemotherapy and monoclonal antibodies, to incorporate targeted therapy for having a step ahead in the therapy of Ph-negative ALL, as we do in Ph-positive ALL. Ph-positive ALL, we use attenuated chemo, monoclonal antibodies, and TKI, but we need this targeted therapy also for Ph-negative ALL. For T-ALL, really, there are no promising, no more news, nor exciting news. Bortezomib has not been useful in children with TALL, newly diagnosed. Yes, in T lymphoblastic lymphoma, but no in TALL. And the most promising studies come from US, combining chemotherapy, nelarabine, PEC asparaginase, and adding venetoclax. And this cocktail provides some improvement in patient in TALL, newly diagnosed TALL patients. So the most important promise for TALL in relapsed and refractory patients came from CAR-T that are really actively investigating in this subset of patients. What about mature BALL? There are many trials that combine the last from our group, combining chemotherapy and rituximab with promising overall response and really promising survival in the order of 80%, and really this is a step ahead in the treatment of Burkitt lymphoma and leukemia, and really the this is our results. No, this is the randomized study combining the specific chemotherapy with a lymphoma type chemotherapy, always with rituximab. Rituximab is essential, and really these are our results showing a good response and a sustained response over time. Well. Which are the questions for the near future? For Ph positive ALL, is we need to definitively establish which is the best tool for MRD assessment. IGTCR by qPCR or by NGS perhaps will be the best than the ratio of BCR-Abelson. Another is to establish the role of allogeneic in first complete response in the era of TKI plus immunotherapy, how to best treat the patients with adverse genetic features, for example, Icaros Plus, which is the role of the new TKI inhibitors, asciminib and especially olverembatinib in frontline therapy, how to treat the minority of patients who will relapse after these very effective frontline therapies, how to manage this, because all the best treatment has been given in first line. What will we do when we patients will relapse? And is there any role of CAR-T for relapsed and refractory patients before transplantation? So there are questions that will be solved in the near future. For Ph negative ALL, the question for the near future is, again, to define the best tool for MRD assessment, one for all subtypes, or there are subtype specific, for example, for KMT2 to a rearrangement. It seems that PCR for the rearrangement is better than PCR for IGTCR. So really, we have perhaps we should select the MRD tool according to the subtype. How to define the best integration of frontline immunotherapy in induction and consolidation. In maintenance, we don't know, so we have to best integrate immunotherapy in frontline. To develop the effective target therapies, for example, the PH-like phenotype, we do not have targeted therapies, perhaps TKI in the Abelson subtype, but it depends, which is the role of immunotherapy in PH-like. how much the chemotherapy can be reduced in the era of immunotherapy. This is very important. If we incorporate immunotherapy in first line, perhaps we can reduce the chemotherapy, and especially there are subgroups, especially elderly patients, who will increasingly be benefited from this reduction of chemotherapy. We'll see CAR-T in newly diagnosed patients with very high-risk features. Why not? So is another issue. For mature B-ALL, Burkitt ALL, we have to have a better approach for the CNS disease. The patients with CNS disease is a especially poor subgroup. The first-line therapy perhaps could be included combining rituximab chemotherapy and the new monoclonal antibodies used in non-Hodgkin lymphoma. How to develop effective therapies for relapsed refractory disease is another big issue for patients with mature B-ALL. And for TALL, we have to improve the knowledge of the biology of the disease, and we have define specific subtypes, for example, better define ETP ALL, and have a specific therapy for this subgroup of patients. Targeted therapies, we need targeted therapies for relapsed and refractory patients. Effective targeted therapies we don't have now. We have to develop effective immunotherapies. The only immunotherapy with some results are daratumumab, and we have to progress in the CAR development for relapsed and refractory patients. This is an exciting area of research that deserves many, I expect many progresses in the near future. Yes, so I finish here. I really have grateful for the 28 hospitals in Spain that are participating in our trials of ALL, and we have a centralized diagnostic in 5 sites in Spain, and there are many clinicians and many young biologists that are progressing in the therapy, in the biology and the study of acute lymphoblastic leukemia. And thank you for your attention.
Thank you so much, sir, for a fantastic and lovely update. And it was eye-opening update for all of us regarding so much of new updates are coming up in ALL. Thank you. And I think from tomorrow onwards, this will be practice changing for all of us. Thank you for updating us with a beautiful insight into ALL. Thanks a lot, sir. And now I request all our discussants to please put the raised sign so that we can start our question answer session. Yes, and we have first Dr. Sanjeev Gupta. Your question, please.
Okay, so first of all, I'll thank Professor Ribera for such an extensive update on the management of BLL. I hope I am audible.
Yes, please go ahead.
Okay. So, sir, as you started in the beginning by saying that there are a lot of new genetic subtypes in BALL, and specifically the PH like category is also taken into account for taking the management decisions and Icaros Plus. So I would like to know what is your approach for doing these genetic testing in BALL patients with regards to which techniques you are using, what is the timing and patient selection for all these?
Okay, so we for reducing the number of other patients, we combine several techniques. We use fish. A fish approach, especially eight panel fish with the main genetic rearrangements of PH like ALL. This is one. We use also a SNP arrays for precis, and we now have incorporated optical genome mapping in this. The combination of this, and we have also a specific panel, NGS panel for pH positive ALL. So we have defining this subtype because this is a subtype, frequent subtype that deserve special attention. So combining these four techniques, we make we distinguish many subtypes, but we identify, especially our focus is to better identify the pH-like phenotype.
So for Icaros Plus also, like, do you add MLPA also, or these
For
techniques?
Icaros Plus, we have MLPA and a SNP array. With these two, with the combination of these two, we identify the Icaros Plus phenotype.
And all the patients undergo this workup, or do you select out patients at different time points?
Sorry?
All BLL patients undergo this genetic workup for all these subtypes?
Yes. We do this, and we do this centralized in our current study. So for PH like ALL, we have identified 15% of our patients that are have this phenotype.
Okay, thank you so much.
Thank you, Dr. Sanjeev Gupta. Dr. Rajan Yadav.
Thanks, Professor, for the talk. I think this is probably the fourth or fifth talk that you've done, and you end up mesmerizing us always. So, my question is not a technical thing, it's rather I'm seeking your opinion. Where do you think what do you think would be the result of CAR T versus bispecifics or and trispecifics in about a decade? Will CAR T still hold the position, or will bispecifics take over?
Yeah, the CAR T could be curative by themselves. And the bispecifics are not curative in relapsed refractory setting. So I think that they are not mutually exclusive. So we can use bispecific for reducing the burden, and then we can use a CAR T for consolidation. This in relapsed refractory setting. In first line, bispecifics have an important role, and really they will contribute to have a step ahead in the results of the therapy. And CAR T in first line in the near future, I am convinced that they will be used for especially aggressive subtypes in first line. For example, KMT2A rearranged ALL, or even another specific genetic subtypes with slow representation. And those who are MRD positive, of course.
Any other question, Dr. Rajan Yadav?
No, thank you. That's all. Thank you.
Thank you, Dr. Rajan. Dr. Arihant, your question, please.
Yeah. Thank you, Dr. Rivera. First of all, I would like to start with one or two questions on TALL. So, TALL, say, if it is a genomically high risk based on the notch or PTEN status, and you want to take the patient to transplant, so do you target a MRD negative state, or in the TLL scenario where our MRD eradication strategies are not as good as we have in BLL, would you be okay in taking up the patient for transplant in, say, a 0.1 MRD as well? And do you use either bortezomib or daratumumab for MRD eradication in TLL?
Okay. The MRD, the dynamics of MRD clearance in TALL is slower than B-cell precursor ALL. So, and I am convinced that the end of induction for TALL is not the best moment to to use MRD for taking decisions. So if you take the MRD level after first consolidation, for example, this is the good value. An MRD, of course, is used in the assessment of TALL because it works very well. And what we have seen, and is very interesting for the patients especially, is that the MRD, the levels in peripheral blood are equivalent than those that are seen in bone marrow. And perhaps in the near future, we will substitute the assessment of MRD in bone marrow by MRD in peripheral blood, just for TALL, not for BALL. So we have good study with parallel samples, and we have demonstrated this clearly. This is for the first questions of you. The second question of daratumumab for clearing the MRD, there is no experience. There are no trials, at least to my knowledge, demonstrating this. The only what is demonstrated by daratumumab is that it could be useful combined with a standard chemotherapy in order for relapse and refractory ALL in children, not in adults. So, and then now there are trials in progress that that combine the incorporation of daratumumab to vincristine, steroids, and asparaginase in frontline TALL in children. So we with these trials we will be able to demonstrate if daratumumab combined with chemo clears better the MRD than just the standard chemotherapy, but it just has to be proven.
So say if the post-consolidation MRD is persisting and the patient is genomically high risk to begin with in a TALL subset, would you take them to transplant directly or would you give nelarabine or?
Yeah, nelarabine is not approved in my country for first line ALL. So when a patient with TALL is MRD positive at the end of consolidation, we put the patient into transplantation because we do not have another tool, approved tool to demonstrate this. Perhaps outside of in a clinical trial, perhaps the use of nelarabine to try to reduce the MRD with nelarabine could be useful, but I am not sure if this will be effectively clear the MRD. I am not sure.
And sir, ETP-ALL being treated on a pediatric inspired protocol, would you transplant in CR1, or if the MRD is negative at say post consolidation time point, you would like them to continue with
What we are doing with ETP-ALL is not treating as standard ALL. So we use a mixed myeloid lymphoid. We begin with FLAG-IDA and in induction, and then we proceed to consolidation with a lymphoid type, high-dose methotrexate, high-dose Ara-C, asparaginase, et and then proceed to transplantation of all patients regardless of MRD level, because this subtype is really a very poor outcome in our hands. So we use a mixed myeloid lymphoid approach followed by transplantation.
And sir, one last question, if I may, Dr. Amit.
Please go ahead.
So in a standard routine BALL, MRD monitoring, how long would you continue, say, once the chemotherapy phase is over? And is it like marrow MRD 3 monthly for first 2 years, 3 years, or you are okay with, say, post-induction, post-consolidation, and pre-maintenance?
Yeah, good question, because really it's easy to establish time points at the beginning. So, end induction, end consolidation, before transplantation if needed, and all physicians follow these time points. When the patient is transplanted or the patient is under maintenance therapy, the sequence of MRD assessment, the theoretical put in our trials is every 3 months in the first year, every 6 months in the second year, and once a year in the third year. This is what should theoretically be done, but really the physicians then sometimes forget to follow this strict regimen, just for because the patient is well, and then they forget, or for resources. So because the sequential MRD monitoring is very expensive, and sometimes is not followed completely in real life.
And thank you, sir. Do you use pegasparaginase in Ph positive ALL in any scenario?
Sorry?
Do you use pegylated, basically use of
no,
asparaginase in
no,
Ph
no.
positive ALL?
We
Not at all.
do not use. We are aware that the German group use PEC asparaginase in consolidation, not in induction, combined with TKI, but we do not use PEC asparaginase in our trials.
Thank you, sir.
Thank you, Dr. Harian. Dr. Ramesh, your question, please.
Thank you, sir, for the elaborate talk. So I need your opinion for one of my patient, is a 34 years male who is a CML lymphoblastic crisis, who was treated with chemotherapy, and he went into remission. But he was not willing for allogeneic transplant, and hence he was continued on dasatinib. On dasatinib, he had a testicular relapse. So TKD mutation was sent, which shows a T315 mutation, and right now he is started on ponatinib, and he is planned for allogeneic transplant. The quantitative PCR done now shows a PCR of value of 3 on IS scale, and his count is okay. He does not have a frank relapse. Is morphologically in remission, but has got a molecular relapse. So how long should we continue? Should I continue ponatinib before taking it for transplant? Like ideally, I'm planning for major molecular remission before taking it for transplant. Should I also consider flow MRD negativity also before taking it for transplant?
What will I do in this patient is continue with ponatinib and adding blinatumomab. And this for this, perhaps the combination could reduce or virtually eliminate MRD and proceed safely to transplant, and then make a local therapy for the testicular relapse, of course.
Okay, sir. Thank you.
Thank you, Dr. Ramesh. Dr. Meenu Angi, your question.
Thank you, sir. My question, am I audible?
Yes, you're audible. Please go ahead.
My question is, what is the role of transcriptome sequencing in the diagnosis of ALL in clinical practice?
Sorry, I cannot hear very well.
Yes, the role of transcriptome sequencing in the diagnosis of ALL in all patients, whether
I don't hear. Amit, can you hear? Can you help me?
This is regarding transcriptome sequencing in the diagnosis of ALL. Is there anything in the field of ALL, anything such as transcriptome sequencing, which can be used as an aid to diagnosis of ALL?
I am sorry, because I don't have any experience in this. I am sorry, I can answer this question because I don't have experience.
No issues, sir.
Well,
Any other question, Dr. Meenu?
one another question.
Yeah.
in myelolymphoneoplasm with tyrosine kinase gene fusion, some patient present as ALL. And in PH like ALL also same rearrangements are there. Is there, they are two different diseases, and whether there is any treatment difference?
Amit, because
Yeah. So the question is about the mixed phenotypic acute
yeah.
leukemia.
Oh, yeah, okay.
In those patients also we have got pH positivity. So is this a different entity, pH positive MPAL versus pH positive ALL, or both are same? And is there any difference in treatment outcomes?
Yeah, a mixed phenotype ALL with pH positivity, we treat exactly as a pH positive ALL. So is what we do, really, if there was pH negative, we begin with a lymphoid type therapy.
Okay, that was the question, right, Dr. Meenu?
Actually, difference between the ALL with tyrosine kinase fusion other than pH, ML and TK presenting as ALL and pH like ALL. Are these two different entities, and is there any treatment difference? pH like ALL and ML and TK presenting as ALL.
So, Amit, is pH positive ALL or pH like ALL and?
So it is pH like ALL versus
Lymphoneoplasm with tyrosine kinase fusion presenting as ALL.
yeah. So pH like ALL versus myeloid lymphoid neoplasm with TK fusions presenting
Yeah.
ALL.
Okay.
Is there any
Okay.
difference between the two?
Yeah, pH like ALL could have some rearrangements that are common with AML. So we treat the patients with lymphoid type ALL, but if the rearrangement is targetable, we add targeted therapy. For example, pues we use if there is FLT3, if there is FLT3 rearranged, we have FLT3 inhibitors. But on the basis, we use a lymphoid type therapy, and we incorporate elements of myeloid therapy according to the genetic background.
Okay. Thank you,
Is
sir.
that satisfy your question?
Thank you, sir. Yes, sir.
Sorry because I did not hear you very well. I am sorry.
Maybe some problems are in the internet. Thank you.
She's asking you the question that regarding this pH like ALL, that is one entity, and another entity is myeloid lymphoid neoplasm with TKD fusions, tyrosine kinase domain fusions. So are the two different things or are the same things? pH like ALL
No,
and
no, no, no.
lymphoid neoplasm.
I think there are different entities. One
Okay.
thing is pH like ALL, another is mixed phenotype ALL, mixed lymphoid myeloid acute leukemia. So no. That I think there are separate entities. They can share some rearrangement, but I think the pH like ALL is almost a pure lymphoid leukemia, and mixed phenotype are mixed acute leukemia. So I think that they are not the same.
Okay. Thank you. Any other question, Dr. Meenu?
Thank you.
Thank you. Dr. Victor, your question, please. Dr. Victor?
Hello, sir. Am I audible, sir?
You're audible,
Hello,
please.
sir. Am I audible, sir?
You're audible. Please go ahead.
Sir, in the era of yes, sir. Sir, in the era of this bispecific antibodies and this CAR T cell therapy, is there any role of this testicular ALL as well as CNS? There is it is century side. Is the role still there is a role of radiation there, sir? Intracranial radiation.
Yeah, for testicular relapse, I think that the best approach is orchiectomy and irradiation of contralateral testicle, and followed by systemic chemotherapy. So even a testicular relapse seems isolated. I think that we have to use a systemic therapy to control the disease as a whole, not only locally.
Okay, sir. Thank you, sir. Thank you, sir.
Thank you, Dr. Victor. Dr. Gopinath, your question.
Good afternoon, sir. Thanks for the elaborate lecture. I think it was a brief outline, covering all the subtypes of ALL. My question is in PH positive ALL. Majority of the LMIC centers, we follow basically BFM-based protocol, BFM plus dasatinib. So in that case, where do you see transplant? Like, because most of your protocols are based on hyper-CVAD ponatinib, but majority of our patients may not be able to afford ponatinib, and we end up doing BFM plus dasa. So in that case, what is the role of transplant?
Yeah, I think that in a BFM type, we also follow BFM type therapy for pH positive ALL. So I think that the most important thing is to assess the MRD at 3 months. If there is less is a MRD 4 or MRD 4.5 molecular response, I think that you can avoid transplantation and give maintenance therapy. It is. If you have the possibility of making an Icarus Plus assessment, if the patient is MRD negative but Icarus Plus positive, I proceed to transplantation. But it is MRD negative, Icarus Plus negative, I do not transplant currently.
And second question as the same extension, like regarding the kinetics of MRD clearance, we have defined protocols like induction A, where we have VCR dono, and induction B, where we have cytosol blocks. And do we have to proceed for transplant? Say, for example, if the patient is induction A positive, at the end of induction A, if he is MRD positive, should that be taken as criteria for transplant, or we end up taking only a day 90 MRD as a cutoff for transplant?
I don't fully understand your question, but
so the question is, Professor, the question is, after the end of induction, if MRD remains positive, should we take for transplant, or should we consider after the end of consolidation, that is day 90?
No. We wait. We wait the MRD assessment for decisions is after consolidation. After induction, there is a high rate of MRD positivity with any TKI. Imatinib, dasatinib, ponatinib. No. This is a bad moment.
Okay. And third thing is, what is the significance of CD73 overexpression in ALL? CD73, CD81, these two markers, are there any role for poor prognosis or something?
I am sorry because I cannot answer because I am not aware of this. I'm sorry.
Yeah, no problem. Thank you.
Thank you, Dr. Gopinathan. Dr. Sandeep Shah, sir, your question, please.
Yeah. Am I audible?
Yes, you're audible, sir. Please go ahead.
So till now we were using blinatumomab and inotuzumab in B-cell ALL, for particularly after relapse to as a bridging therapy before transplant. But if now adult ALL, if somebody wants to avoid transplant, do you recommend that blinatumomab should be used in every patient as a first-line therapy or as a consolidation therapy?
Really the times are moving to incorporate blinatumomab. I am not sure that it will be the same of inotuzumab, at least in phase 2 trials. It should be incorporated, in my view, earlier, not only in consolidation, but also in induction. So if we use this induction and consolidation use of blina or ino, really, and there is a deep MRD negativity, one should question the need of transplantation. One should question, but it has to be proven. No, is not clear because the phase 3 trial, the E1910 that was published in and given the acceptance of MRD for consolidation, a small fraction of patients received transplantation. But the vast majority of patients were not transplanted. So really, the effect of transplantation has not been very well studied in this trial. But in any case, most of patients were not transplanted, and perhaps, especially if the patient is older and has risk factors for transplantations, because and achieves a deep MRD negativity, perhaps I should not transplant this patient.
Second question is in relapsed T cell ALL. How will you rate nilarabine? Because in most of our patients, I have never seen response to nilarabine. So how do you rate nilarabine in a relapsed refractory T cell ALL?
Yeah, we do not use nelarabine as single drug in relapsed refractory TALL. We combine with cyclophosphamide and etoposide. It is the NECTAR study. And we try to put the patients in complete response and quickly move to transplantation. The results, the combination of nelarabine, cyclophosphamide, and etoposide provides by top 40% of complete response, and these are response of short duration. It's very important that we can move quickly to allogeneic stem cell transplantation.
Thank you. Thank you very much.
Thank you, sir. Dr. Manthan Kathrotia, a question, please.
Thank you, sir, for that nice and comprehensive talk. I have two questions. First is related to Ph positive ALL. I have a patient who is 40 years old, and she was a late responder initially. She couldn't achieve MRD negativity. So we took her into MRD negative state with use of blinatumomab and TKI. And later on, we did a haploidentical transplant with sister. So after that, she was in remission. All the assessments were okay. And gradually, after 6 months, her chimerism started dropping. Somehow she was in another country, so she could not come back. We could not give DLI or anything for that dropping chimerism. And right now she has presented to us. We evaluated her. Her chimerism, donor chimerism, is only 5%. There is a complete autologous recovery, and disease evaluation is showing MRD negativity as well as BCR-ABL negativity. Quantitative BCR-ABL is negative. So she is on ponatinib since post-transplant on maintenance. So what can be the further treatment plan? Should we transplant her up right now, or should we continue ponatinib?
So Amit, can
Yeah,
we?
I will just brief you out the whole case. He has a case of Ph positive ALL.
Yes.
Went into MRD negativity very later on after the consolidation. And after that, the patient was transplanted immediately. The patient went into MRD with the incorporation of PONA plus blinatumomab in Ph positive ALL. The patient was then transplanted, and it was a haploidentical donor transplant with sister as a donor. Just few months after the transplant, the chimerism is falling down, and now the chimerism is only 5%. But MRD is still negative, both flow-wise as well as by molecular-wise. But the chimerism has dropped to 5%. The patient was not was transplanted from another country, was going another country, so DLI was not the option available. So the patient was not given any DLI. But the chimerism, right now, the chimerism is only 5%. Patient hematologically has not relapsed. MRD is negative. Molecularly also, MRD is negative, flow-wise as well as molecular-wise. Should we go for a second transplant or to continue with only ponatinib as the maintenance, ponatinib?
I could continue maintenance therapy with ponatinib and make a strict follow-up of MRD. The discrepancy of chimerism and MRD is not usual, but I think that MRD should weight the post-transplant decisions instead of chimerism. So for that reason, I will follow MRD as the tool for decisions of therapy. And in this case, despite being continuously MRD negative, this loss of chimerism made prone to continue with ponatinib maintenance at least for 2 years more.
Thank you.
Okay, thank you, sir. Another question, if I may ask.
Yeah.
Yeah, there is another patient, sir, of TALL. She's a 34 years old female. Initially, she was on BFM protocol and relapsed while she was on reinduction phase. So then a single agent nilarabine was given, but she didn't respond to that at all. The blasts were persistent. After that, she presented to us. Because she had some neurological side effects with nilarabine, so we gave her FLAG-IDA protocol. But with that also, after 3 weeks, her marrow was almost full of blast, 50-60% blast. So now we have given her a combination of nilarabine, cyclophosphamide, and etoposide. And post that also, the recent bone marrow, which we have done after 20 days, is still showing 50% blast. So how should we proceed further in this case?
It's a difficult case. It's a difficult case. But if you have BCL2 inhibitors, say venetoclax, perhaps venetoclax in combination, mini hypercibat venetoclax and PEC asparaginase perhaps could be a combination to be tested. This is clearly a refractory patient, and I do not expect many good results. But if you can try to introduce BCL2 inhibitors, venetoclax in combination.
Okay, sir. Thank you very much.
Thank you, Dr. Banthan. Dr. Fahima Hassan, your question, please.
Am I audible, sir?
Yes, you're audible.
Yeah. Hello, sir. It was a very comprehensive talk. Thanks for it. My question is regarding pH positive BALL. We had a 35-year-old female. We induced with hypercvad and dasatinib, and she was followed up with maintenance for 2 years. Now she has been MRD negative all the time, and I have been monitoring her BCR ABL. Currently, from major molecular response, her BCR ABL is on the rise, and this is a time to stop our TKI. Dasatinib. It's been 2 years since maintenance with TKI. What should I do? What should be the way we should counsel? What could be the underlying mechanism here? Like her bone marrow MRD also, I got it done. At the end of 2 years of maintenance, it was negative. It's still negative, but BCR ABL is on the rise from major molecular response to 0.12.
So the question is the duration of maintenance therapy with dasatinib?
So she has a case of pH positive ALL treated with dasatinib plus hypercvad.
Yes.
After that, the patient went into molecular MRD negativity. Right now, also the patient is flow MRD negative, hematologically in CR, but the BCR ABL is rising, and it has risen from MMR, major molecular response, to it has become 0.12% now. So now it is exactly 2 years of stopping the TKI. Should we stop TKI or continue with it? Because the BCR ABL is rising from 0.1% to it has become 0.12% now.
Yeah, no, but the MRD is rising.
Yes,
is
ABL,
rising.
molecular.
And when this is rising, which is the therapy now?
Right now, the patient is on TKI, maintenance TKI.
Yeah. So
And 2 years, 2 years.
I think, if possible, we should make a mutation study But sometimes with this low level of MRD does not allow to make this study. But in any case, I would change to ponatinib. Perhaps as the if there is raising, it's a dangerous situation, and perhaps I could combine ponatinib and blinatumomab and make a quick follow if there is a descent in the MRD level. I will follow strictly. But if there is not a quick elimination of MRD, I should move to transplantation. Yeah, but it depends of the kinetics of MRD after ponablina.
Exactly. Thank you so much, sir. Yeah.
Okay.
Yeah. Dr. Radhika, your question, please.
Thank you, sir. Thank you for the comprehensive and fascinating talk, sir. So I have an 18 years boy, a Ph positive ALL, treated with UK ALL based protocol plus TKI. Imatinib. I have used imatinib in this patient because he was intolerant to dasatinib. I did consider him for a transplant because post-induction and post-consolidation, he was MRD negative. He was MRD negative by flow always, but he never attained an a major molecular response to the extent of 4 and 4.5. He was always MR3. Now he is 1 year post-maintenance, completed his maintenance an year back. He is presently on imatinib 400. He still has a persistent BCR positive in the range of 0.2 to 0.4. That is MR3. So what do I do? How long should I be continuing imatinib here? Or should I be switching over to a second line TKI? Or should I be preparing him for a transplant?
Amit, help.
The question she has is again of Ph positive ALL.
Yes.
This young boy who has
Yes.
been treated with imatinib plus UK adult ALL protocol.
Okay.
And the patient went into MRD negativity by flow, but remains as MRD positive molecularly with only MR3, that is at the level of 10 raised to minus 3. So the thing is basically right now also after 1 year of maintenance with imatinib 400 milligram, he has the BCR-ABL positivity at MR3, basically. It is not going down from MR3. So whether to continue with imatinib, to change to a second generation under TKI, or to go for transplant, what would be the best option now?
Now the patient has long time MRD3.
Yes.
So if the patients could relapse, perhaps it would relapse it yet, but really MRD3 level is not a good MRD level. So I'll try in this case. Perhaps I associate blinatumomab to imatinib. Perhaps I could not change the imatinib because the patient is very well under imatinib, but I could incorporate blinatumomab in order to achieve an MRD4 or 4.5. And perhaps it could be done and maintain then the imatinib. So perhaps I will wait the transplantation for a further increase. But if we decrease the MRD to 4 or 4.5, I should continue with imatinib maintenance indefinitely, and wait and see. I don't know.
Yes, sir. I have a second question, sir. So in newly diagnosed ALL, when we are adding blinatumomab or inotuzumab in the consolidation phase, do we reduce the do we modify or reduce the doses of the existing chemotherapy, or we continue with the same doses of chemotherapy when we are adding an external monoclonal antibodies?
So,
Amit.
yes, he has a question regarding pH negative B cell
Yes.
ALL. When we are adding inotuzumab in induction and blinatumomab in consolidation to the existing chemotherapy, should the dose of the existing chemotherapy be reduced along with that, or at the same dose?
So chemotherapy has not been done yet, no, in this patient?
No, this is just a theoretical question. If the patient is
Yeah.
between INO in induction and Blina
Yeah,
in
yeah,
consolidation,
yeah. Yeah. I think that this approach is good for putting the patient in complete response, but I think that is insufficient to maintain the response. So I could give to this patient some kind of consolidation with chemotherapy.
and the dose of
And
chemotherapy should be reduced.
No, BFM type chemotherapy, high dose methotrexate, high dose Araci and asparaginase, in order for two reasons. One, to consolidate the control of the systemic disease, and second, to protect the CNS, because the INO first Blina then does not protect the CNS, and really I think that it should be protected because the 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 risk of CNS relapse in this case is high.
Exactly. So with the same dose.
I have a third question, Dr. Amit.
Yeah.
If you- Last question. So, sir, newly diagnosed adult ALL, I generally treat them with UK-based protocols. So, as per the UK protocol for adult ALL, there is the incorporation of an anti-CD20 or rituximab during the consolidation phase. So, what is your do you practice that addition of an anti-CD20 like rituximab in the consolidation phase routinely for a CD20 positive adult ALL?
Yeah, the question is the use of rituximab during consolidation.
Yes, exactly, sir.
Yeah. Really, I think that if the patient is CD20 positive,
Yes, sir.
rituximab should be used not only in induction, but also during consolidation and maintenance, because there are two studies. Well, the randomized French study demonstrated that I guess that 18 doses of rituximab during induction, consolidation, and maintenance, and they showed an improvement in event-free survival. On the contrary, the British study giving rituximab only in induction in a randomized way, they did not demonstrate any effect on the event-free survival or overall survival. So if we use rituximab, you have used rituximab throughout the therapy of ALL.
Okay, sir. Because the protocol was showing rituximab only during the consolidative phase in the UK-based protocol.
Yeah.
So,
Yeah, I think that you should continue.
sure, sir. But do you practice that in European practice also?
Sorry?
Do you practice this rituximab, addition of rituximab in European protocols, sir, in your protocol?
Yeah. In our protocol, we give an advice for using rituximab throughout the trial in CD20 positive ALL, but this is an advice because we cannot put as mandatory because rituximab is not approved in Spain for ALL. So it's just a recommendation, not mandatory.
Thank you very much, sir. Thank you, sir.
Thank you, Dr. Radhika. So there are some couple of questions from the audience, and I will just start with from Dr. Sitharam Anandram. Any role of inotuzumab if Blina is not available in pH positive ALL?
Well, good question. Inotuzumab is effective in pH in ALL in general, but pH positive and pH negative. So I think that if Blina is not available, inotuzumab is an option. Yes.
Perfect. Another question from Dr. Shyam. pH positive ALL on blinatumomab plus ponatinib. What is the medium time to achieve CMR?
The question is how, when?
Plus
When?
Blina. Pona
Eh?
plus Blina, pH positive ALL. How much time it takes to achieve CMR?
Well, the first assessment is after induction, but it's just informative, no question. And the most informative is at 3 months. And at 3 months, we have to take a decision. But if the patient is in complete molecular response, you can continue, and perhaps no follow, just follow. And if the patient is MRD positive, I should transplant this patient.
Perfect. Another question is from Dr. Shyam. pH negative ALL, MRD positive. Would you prefer CAR-T or stem cell transplant?
Now, the only approved thing is transplantation, but there are clinical trials in this situation in CAR-T in first line, but we do not have results of any of them.
Thank you. Another question from Dr. Tarek. ALL, pH positive ALL. Do you recommend doing both molecular plus flow or only molecular?
Nice question. So I think if I have to choose just one, perhaps I choose IGTCR, not BCR Abelson, because the CML like ALL could have discordant results.
Thank you, sir. In your country, this is the question from Dr. Hitabi. In your country, what protocol do you use for BALL? What protocol do you use for TLL? And what protocol do you use for Burkitt lymphoma first line?
Yeah, for B and T ALL, pH negative ALL, we use a BFM type protocol. For pH positive ALL, we use imatinib chemo with quick moving to ponatinib if not complete molecular response. And for Burkitt ALL, we use blocks. He used one protocol derived from the German trial, blocks of chemo plus six blocks of chemotherapy plus rituximab.
Thank you, sir. And for TLL?
For TALL, the same as BALL.
Okay, sir. Another question from Dr. Hitha B. When do you transplant in Burkitt?
Transplant in Burkitt, we do not do this because autologous transplantation has no role in Burkitt ALL, and allogeneic transplantation in first line we do not use, and in as relapsed Burkitt ALL does not provide any effect. So transplantation in Burkitt is, I think, it's not indicated. Okay, but if you have a relapse and you put the patient in second response, that is very difficult. But if you achieve the response and try to transplant, why not? But there is not an true effective. There is not a graft versus Burkitt leukemia.
Thank you, sir. And the allo transplant in TLL only in CR2 MRD positive, right?
We transplant for TALL. We transplant MRD positive patients at consolidation or ETP ALL, ETP all patients regardless of MRD.
Thank you, sir. Another question from Dr. Ashok Meshram. He has a 6-year-old child who is pH negative, precursor B cell ALL with isolated testicular relapse after 2 years of treatment, started on modified ALL R3 UK adult ALL protocol, has got no HLA match. Can he be given inotuzumab to the salvage therapy?
Inotuzumab is better therapy for extramedullary relapses than blinatumomab, it's clear. But I should combine inotuzumab with chemotherapy because treat the testicular relapse, of course, locally. But I think that inotuzumab works better if combined with chemo in relapsed refractory situation. But if you don't do anything else, Yes, I should, it is a limit of transplantation because there is a late relapse, but not very late relapse. Perhaps it could be managed with and chemotherapy, but I am not sure that if patient also will need an haploidentical transplantation from the fathers, from fathers, perhaps no. If there is not an unrelated donor, an haplo donor is usually available. In my case, I should INO plus chemo and allogeneic haplo transplantation. I did I recommend this with some doubts about transplantation. Some doubts.
Thank you, sir. Another question from Dr. Ashok Mishra. How do you treat pH positive MPAL?
Yeah, as pH positive ALL.
Great. Another question from Dr. Kannan. Do you offer CAR T cell therapy for relapsed B cell precursor ALL upfront?
CAR for relapsed
upfront. Relapsed
well, if the relapse is after allogeneic transplantation, yes.
Otherwise, first allo, then CAR T.
No. Otherwise, first allo and then CAR T, if necessary.
Perfect. Another question from Dr. Prakash Nidhi Tiwari. What are the recent advances in the classification and treatment of infant ALL?
Infant ALL, so?
Yes.
The treatment.
Treatment as well as the classification.
Yeah, infant ALL are KM2A positive or not. KM2A positive should be included in a specific trial for this patient, including blinatumomab in induction, and for the remaining, you should treat as the remaining B-cell precursor ALL. 75% of infants are KMT2A rearranged ALL, and 25% are a standard B-cell precursor ALL. So it depends, the trial depends on the presence of KMT2A rearrangement.
Perfect. Another question from Dr. Prakash Tiwari. Would you take into account high throughput point sequencing in modifying the post-induction treatment of ALL?
Sorry?
Would you take into account high through point sequencing in modifying the post-induction treatment of ALL?
I don't I don't understand the question.
So it's regarding the sequencing method and regarding the sequencing method post-induction treatment of ALL, and that is high throughput point sequencing, which is being the advancement in the sequencing, that is high throughput sequencing. So would you go for that high through output sequencing in the MRD monitoring?
We use in Spain, we use flow we next generation flow. We do not use next generation NGS. We do not use because it's expensive, time consuming, and we do not have access to the automated tool such as ChatGPT in US. So that they have in US there is a tool, a validated tool by FDA for MRD assessment by NGS. We do not have this tool in Spain, so we are managing with next generation flow.
Great, sir. Another question from Dr. Hitha B. In a case of T lymphoblastic lymphoma, bone marrow not involved, would you use a PET-guided approach in upgrading the treatment?
Yes, we treat as TALL and we make the control with PET-CT scan.
Perfect. Another question from Dr. Saurav Mishra. Is MRD negativity a better prognostic marker as compared to day 8 blast clearance in ALL?
MRD negativity is the best tool, the best single tool for monitoring the response to therapy in ALL.
Thank you, sir. Another question he has is, how important is maintaining a dose intensity of chemotherapy in
Yeah.
ALL patient?
Yes.
Because some patients have got toxicity with the dose. Should we reduce the dose? And that will hamper the outcome?
Yeah, really is a very important question, especially for adult ALL, and has not properly addressed. In children, it's clear. Dose intensity matters. In adults, it has not been studied, but I guess that it's also important. But it has not been studied.
Thank you, sir. And another question from Dr. Deep Gala. For pH positive ALL, can we use ponatinib plus chemotherapy for induction, consolidation, and switch to dasatinib in maintenance?
No. We maintain the same TKI if there is response in all phases of therapy of ALL, pH positive ALL.
Thank you, sir. Another question from Dr. Tarek Ben Othman. What is your opinion about the use of blina after allogenic stem cell transplant who remain MRD positivity?
There are a limited number of studies. It's feasible. This is clear, but really, what is not clear if this provides better overall survival. It's feasible because it's not toxic. Converts the patient in MRD negativity, it's very probable. But if you don't do anything, the problem is that this patient could relapse. It's at risk of relapse. So I think that blina is good for putting the patient in an MRD negative status, but I am not sure if this is sufficient.
Thank you, sir. Another last question from Dr. Akanksha. In a case of pH positive ALL, 40 years male, post-induction MRD is positive with dasatinib. Hence was shifted to ponatinib with chemo and continued the BFM protocol. Patient attends CMR at 4 months, did not opt for transplant. Now, how long should the ponatinib maintenance be continued?
Yeah, the duration of maintenance is not well established in non-transplanted patients, but my advice is at least 5 years.
Great, sir. Thank you so much, sir. Aryan, do you have any other question? Dr. Aryan?
Yeah, so thank you for those series of answers, first of all. And so my question is regarding a couple of our patients have CNS involvement at the time of diagnosis. Few of them maybe say the CSF cytology is positive, and a couple of others where say they have a facial nerve palsy at the time of presentation. They are yet to receive a CNS directed therapy. So in those cases, do you recommend a transplant to all approach? I mean, transplant all of them just because the fact that they had CNS involvement, or a good CNS directed, say, methotrexate and intrathecals are sufficient if they achieve the medullary MRD negative state otherwise?
No, I think that the CNS involvement per se is not a risk factor for ALL. If you control adequately the CNS disease, the patient should be managed as the regular patients. Is not a risk factor accepted in many trials.
Okay, thank you, sir.
Dr. Aryan. So any other discussion? Has any other question?
Can I ask a small doubt to
Yes, please go ahead.
Professor Rebel? Thank you, Professor, for such an enlightening talk. I just had one query. This study which you mentioned where inotuzumab was used for induction, followed by blinatumomab for consolidation, and the response you said it was a chemo-free trial where the response was almost up to 80%. I just wanted to know did you have anything towards case selection, or did you include high risk cases also in this?
So your question is if I know first, then Blina should be used for a selected subtype of patients.
Yes. Yes, sir.
Well, the ideal subtype of patients, these are elderly patients, so that they could tolerate a chemo-free regimen, no? But as I said previously, uh, uh, the, this trial, this approach ensures virtual no treatment-related mortality in induction, and this is a big issue. But I think that once the patient is in remission with this approach, the patient should be consolidated in chemo with chemo, attenuated chemo, but chemo in order to protect the CNS and in order to ensure the better the deepness of response, provided that the patient is in good health status. When in remission without toxicity, the elderly patient could tolerate chemo. And I think they need some form of chemo to maintain the response achieved by the Ponablina combination.
Thank you.
Thank you. Another last question from Dr. Hassan. Fahima Hassan, please, the last question.
Yeah, sorry, sir. Last time I asked the question, my internet was a problem. So this pH positive patient induced by hyper-CVAD at 4 cycles, followed by 2 years of maintenance on dasatinib, and now on the third year of follow-up with just BCR-ABL positivity and flow negative MRD. Should I give Blinat, like Sir said, I think ponatinib and blinatumomab to be given, but she's MRD negative on bone marrow. Only BCR-ABL is positive at a rate of 0.012. So I was contemplating stopping dasatinib. That is the reason I got the BCR-ABL done. But then it was from MMR to 0.12, but bone marrow MRD is negative. PET-CT is negative. Only BCR-ABL is on the rise. Should we still contemplate Blinat in this patient, sir?
Amit, can we
Sir, you already
summarize?
answered this question. This is the same case what she had put up before also. A patient of pH positive ALL. Right now, patient is MRD by flow negative, but
Yes.
positive by BCR ABL, and it has just risen up from 0.1 to 0.12% only
Yeah.
on fertility maintenance. Should we change to another TKI, or should we add blinatumomab at this point? Because is there any point of adding blina to make it as MRD negative, because it is just molecularly 0.1 to 0.12 of BCR-ABL, and by flow it is negative.
Yeah. Perhaps in this case, I should make a PCR for IgTCR. And if this is negative, I will not change the approach. And if this is positive, I could change to ponatinib and blinatumomab. So it could be a CML-like pH positive ALL, this case.
Exactly. Yes, sir. Yes, sir. That is my question. Whether I should really go for some Blinat or just ponatinib would be sufficient. So you would like to do a TCR MRD and then decide, is it?
Yes.
Okay. Thank you. Thank you so much, sir. It was a
Thank
very
you.
comprehensive talk. Thank you.
And last question, sir, from Dr. Ariyant. In maintenance, do you give steroids along with 6-MP and methotrexate?
Yeah. The question is if we use CX, so mercaptopurine and methotrexate as standard maintenance without reinductions.
No. The question is regarding whether to use only 6-MP methotrexate, that is sufficient in maintenance, or should we also add steroids?
No. I make the combination mercaptopurine and methotrexate. Yes.
That's sufficient. Okay. Thank you, sir. So that was a long Q&A session. And what a wonderful answer, sir, you've given. And the knowledge you have is tremendous in this field. Thank you so much for updating us, solving all our doubts today. It was a beautiful session, wonderful lecture, and above all, a wonderful discussion. Thank you so much once again. And I also thank all our discussants and audience to join up here today. And again, meet you next Saturday, Sunday. So a special thanks to you, sir, once again. Beautiful lecture, wonderful lecture, covered over all the things and solved many doubts of us. It was crystal clear. Thank you so much, sir.
Bye-bye.
Thank you.
Thank you.